I would now like to introduce Professor Manuela Ferreira, who is the Principal Research Fellow and NHMRC Investigator Fellow. I also want to take this opportunity to thank Manuela for organising this session.
Thank you so much, Lauren, and thank you for the opportunity to discuss management of back pain with you and with all of the attendees. So I too would like to start by acknowledging the traditional custodians of the many lands where we meet, and pay my respects to elders past, present, and future. So I'll start by sharing my screen. All right. And I believe you can see the right version of my screen.
Yeah. All good, Manuela. Thank you.
Thank you so much. So just very quickly going through the running order. So I'll start by introducing the panel and the speakers today very briefly. I'll then go on to discuss a little bit, just about 10 minutes, an overview of the burden of low back pain. So this is pretty much, we're all aware of the high burden of low back pain, not only in Australia, but globally, but we have a few slides to discuss that. And then I'll invite Miss Melissa Gilbert, who is a consumer, so someone with lived experience in chronic pain, who has very kindly agreed to share with us her experience and her perspectives. So Melissa will share that right after I talk about the burden for about 10 minutes as well. We will then have Dr. Christina Abdel Shaheed. So Christina is a pharmacist and a senior lecturer at the University of Sydney School of Public Health, and she will discuss pharmacological management of back pain. We then have Professor Paulo Ferreira, who's professor of musculoskeletal health as well at Sydney University School of Health Science, and an expert on exercise and digital health for back pain, and he will be discussing on pharmacological management of low back pain. I'll come back. By then you will be tired of hearing my voice, but I'll come back and talk briefly about the evidence on surgical management, and then we'll have the panel, all four of us here for you to ask questions. Please use the Q&A chat or box in the bottom of your Zoom for any questions, and I'll be facilitating that. All right, so we'll start now. And again, I'll very briefly just discuss with you the burden of back pain. So this is the next few slides are actually from the Global Burden of Back Pain, or the GBD, the Global Burden of Disease report on back pain that has been very recently published. The Global Burden of Disease study is a study coordinated, funded by the Bill and Melinda Gates Foundation and coordinated by the University of Washington. And what they do is they quantify health loss at the global, regional, and country levels over time. So since 1990, they've been doing this, and there is an ongoing updating of data and information that they collect, and they rerun the analysis to look at that burden, in our case, in terms of disability, not mortality, over the years. One of the biggest advantages of the GBD is actually allow comparison of burden across diseases and across regions of the world. So we know that since 2010, so the report published in 2010, back pain has been recognized as the #1 cause of disability worldwide, disability measured as years lived with disability. Now, this is the latest, or the second latest report from the GBD in using data from 2017. And again, what you can see there at the top is back pain as the #1 cause of disability in the world across all conditions, all countries, all regions, the #1 cause of disability in the world. Now, what we can see in the left column there is a negative number showing that even though in absolute numbers, that burden, that prevalence has increased, in terms of age standardized rate, there has been a small decrease in that burden. The latest report was published in May this year in Lancet Rheumatology, and these are the very fresh results of that report. So right now, it is estimated that about 619 million people in the world, or 7% of the global population, now that rate is the age standardized rate, reports back pain. These are cases of disabling back pain. So not only any back pain, but disabling back pain. This is an increase of 60% in numbers, in absolute numbers or absolute prevalence from 1990, but again, a slight decrease in terms of age standardized rates. And that report also showed that low back pain accounts for about 43 million years lived with disability around the world. And this map shows you that the darker colors represent the highest prevalence. So it just shows you a little bit of the prevalence around the world. Now, we also learned from that report that women tend to have more back pain than men. We know from past research, including research from our group, that this is not a biological difference. So in twin studies, what we have learned that there is no obvious or apparent or identified biological reason or cause for back pain to affect women more than men. So this is probably reflecting the fact that women report back pain more than men, or tend to seek care for back pain more than men. So that's why you see that prevalence. But very interestingly, what we can see is that the peak prevalence of back pain is around 85 years of age. So unlike what was believed maybe 20 years ago, when the peak prevalence of back pain was believed to be at around 55 years of age, we now know that the disabling back pain tends to be more common in the older age, especially the older old age. Now, we also learned from that report that by 2050, we expect 843 million people around the world to be impacted by back pain, which is a 36% increase in prevalence, mostly driven by population growth, even though in some countries or some areas of the world, that increase is driven by aging. But these are the two most probable causes or reasons for that surge in number of cases of back pain: population growth and population aging. In terms of risk factors, so we know that there are a number of different risk factors for back pain. These are 3 risk factors identified in that report as being important risk factors because they account for about 40% of the burden of back pain. So these are work-related ergonomics, obesity, and smoking. We've known that work-related ergonomics or work-related activities are highly associated with new episodes of back pain. So we saw that in a paper published in 2014, the triggers, based on the trigger study. So this was a case crossover study looking at the risk associated, the risk of those factors associated with a quick or a sudden onset of back pain. And what we learned was that carrying heavy loads, working in awkward postures, carrying objects not close to the body, and carrying loads that were unstable or unbalanced. So all of those were actually associated with low back pain, with a new risk of low back pain. And you can see here that this is across all ages. So most of these factors were not moderated by age. Now, we also know from past research conducted all over the world that other important risk factors have been associated with back pain. So some of them not modifiable, such as age, and we've talked about this. Having a previous episode of back pain does increase your chance of having a new episode of back pain. But again, there is not much we can do about this. But other factors such as sleep problems, prolonged standing and walking, and time driving, all of these are important risk factors as well. Now, very quickly before we move on, still in terms of burden of back pain, we do know that for people with an acute episode of back pain, so people who have had an episode of back pain for less than 6 weeks, 2/3 of them will actually recover. But even with those who do recover, 1/3 of them will have a new episode of back pain. So 1/3 will become chronic, and among those 2/3, many of them, again, 1/3, will have a new episode, which is one of the reasons why we're seeing this surge in absolute numbers or prevalence of back pain. Again, what causes, what's the reason for a new recurrence of back pain? We looked at some of the data that we had, and the only predictor for a new episode of back pain was having had back pain before, which is really not very helpful. All right, so this is again, I'll stop sharing my screen now. But this is again just a very brief overview of the burden and impact of back pain and some of the probable risk factors. We're not talking about causes, we're talking about risk factors. But I'll stop talking about burden now, and I will invite Miss Melissa Gilbert to please share her experience. First of all, I want to thank Melissa for agreeing to talk to us and share her experience, but I'll then pass it on to Melissa to tell us about having chronic pain. Thank you so much, Melissa.
Hi, thank you. And hi, everyone. So I'm coming from the beautiful Wurundjeri land here in Melbourne, and pay my respects to elders past, present and emerging as well. Goodness, where to start? So I think back pain, like chronic back pain especially, it's something that a lot of us don't even really think about so much anymore, as it's just something that we have to live with day to day. After Manuela and Paulo invited me to contribute here, I really actually had to quite think about what my experiences are, as it's something that I've had for quite some time. And I guess the thing is, often you get to a point where, as you know, Manuela mentioned, that a lot of people have that ongoing back pain where it's, you know, repeated episodes and that kind of thing. And sometimes you're going to the doctor and they're asking you, when did this start? And you're like, I can't even remember. This has, you know, gone on for so long, not even remembering a specific event where this has started. And I think in terms of my experiences of, say, with seeing doctors to do with my back pain, I've had some really good experiences where I've had doctors say, refer me on to do some, say, like some exercise treatment, or to see a physio or osteo or someone like that to sort of do a bit of a combination of, you know, treatment and exercise. But I've also had some other experiences where I felt like really brushed off, or where a GP has just basically said, oh, well, that's what happens when you have a baby, apparently, is that you have back pain. And that, you know, you can't even bend over to put your baby in the cot, which I realise is not really very helpful or true. Or other times, you know, just pop some Nurofen and you'll be right. And I think that sometimes that bigger picture of the kind of effect that it has on your life really isn't necessarily considered, you know. With back pain, it's basically all the time. And like, at least for my experience, and I know quite a few of my friends, there's a point where it kind of doesn't really go away completely, or not for extended periods of time. So there's no, I'll walk it off, it'll get better, or lay down for a bit or anything like that. It's that constant having to go in between different postures or doing different things, and it affects you working. So I might be in the middle of writing something up, got the whole brain going at full speed, but need to go and have a walk for 10 minutes because I just can't sit down for any longer. Or it affects doing activities with your kids. So like I can't drive for much more than an hour. It can cause a lot of pain. So that means, taking day trips with my kids, or doing certain activities can be really difficult. When they were little, getting down on the ground to play with them was something that was really difficult. And also even keeping up with friends. There's times where I've had to, cancel plans or leave early just because, walking around or sitting for a long time or doing whatever we were doing just really wasn't going to work with me trying to manage my pain myself, or I've just been so unwell that I haven't been able to go at all. So I guess, sorry, I haven't really kept track of time very well at all. But I guess I think from my perspective, I guess a take-home message would be, when you're speaking to patients about back pain, believe them. People aren't saying these things lightly. Like Manuela said, like it seems that there's even a lot of people that don't report their back pain as well. And just think about the impact that it has on their whole life, and how that can be really quite overwhelming and really disheartening for people, especially when there's not a quick fix of a, pop one tablet and it'll go away, or, that it's something that really takes work or a lot of different treatments to try and manage.
Thank you so much, Melissa. I do have a couple of questions for you, but I think
Sure.
I'll save my questions for when we have the panel discussion.
No worries.
Just out of respect for the audience who is not allowed to ask questions at this moment.
We'll be fair.
Yes, but thank you very much, and again, we really appreciate your your honesty in sharing your experience with having chronic back pain.
Thank you.
And now we are going to move on to Christina's presentation. So unfortunately, Christina had a last minute personal problem that she couldn't be here, well, in person, virtually. She will try and join us for the panel discussion, but she's very kindly sent her recorded session. So Lauren, if you would like to please share your screen and Christina's recording. So Christina is going to be discussing pharmacological management of back pain based on the latest evidence. Thank you.
My name is Dr. Christina Abdel Shaheed, and today's presentation will be on medicines for low back pain, where we are and where from here. Firstly, I'd like to recognise and pay respect to the elders and communities past, present and emerging of the lands that the University of Sydney's campuses stand on. For thousands of years, they have shared and exchanged knowledges across innumerable generations for the benefit of all. So just a brief outline of the presentation today. I'll be looking at the major drug classes that are commonly used to treat back pain in the community and also in other healthcare settings. And we'll also discuss directions for future research, and very keen on your input for this section. First, to start with paracetamol for acute low back pain. So there was a study published in The Lancet in 2015, which looked at both modified and immediate release preparations of paracetamol, and basically found that they were no more effective than placebo for acute back pain. So whether a modified release preparation taken regularly for a couple of weeks, or whether an immediate release preparation taken on an as-needed basis up to 4 grams daily for a couple of weeks. Neither of those regimens were more effective than placebo for acute back pain. For chronic back pain, on the other hand, there's inconclusive evidence regarding the efficacy of paracetamol, whether it was immediate or release or extended release. And we also don't really know what the potential opioid-sparing effects of paracetamol in the context of chronic back pain is. So a number of general practitioners might prescribe paracetamol for people with chronic back pain as a way to reduce the requirements for potentially dangerous medicines such as opioids or gabapentinoids. And it'd be good to quantify the opioid sparing effect of paracetamol in this context. At the moment, we don't actually know what that would look like. Moving on to opioids. So there was a recent study published also in the Lancet which showed that an extended release preparation of oxycodone combined with naloxone up to 10 milligrams twice daily was no more effective than placebo. And it tested this regimen taken for a period of up to 6 weeks, but typically most participants received around 2 weeks of the treatment, and there was no benefit above that seen with placebo. For chronic back pain, on the other hand, we found that there was a small benefit with opioid analgesics in the short term, so less than 3 months post-administration, and they reduce, on average, pain by about 10 points on a 0 no pain to 100 worst pain imaginable pain scale. There was also very small pain relief seen in the intermediate term, so there was about an 8-point reduction at that time point. But interestingly, many participants actually withdrew from the studies due to adverse events or lack of efficacy, so greater than 50%. And because a lot of these trials were enrichment design, where people are entered into a run-in phase, in other words, everyone gets the medicine at the beginning, and then those people who are able to respond to the medicine and tolerate the medicine are then entered into the trial phase where they're randomized to either the placebo or active medicine. So to see such a large dropout in those early stages, the run-in phases, but also in the actual trial phase, does give a bit of an indication that there may be people in the community who might not be able to tolerate these medicines and who may not respond to these medicines. So we need to think about potential alternatives for those individuals. Looking at muscle relaxants for acute back pain, there's very low certainty evidence that non-benzodiazepine antispasmodic muscle relaxants provide very small reduction in pain within 2 weeks of administration. So they reduce pain by about 7 points on a 0 to 100 pain scale. You can see the list of muscle relaxants that were evaluated here. Most of them aren't actually available in Australia, but we do see quite a bit of orphanedrine. Certainly as a community pharmacist, I see quite a bit of orphanedrine dispensed and prescribed for the treatment of back pain. There was an increased risk of non-serious adverse events with these medicines by about 60%. So you can see the relative risk there was 1.6 with a confidence interval ranging from 1.2 to 2. And that's based on quite a number of studies with over 3,400 participants. For chronic back pain, on the other hand, there's inconclusive evidence for any benzodiazepine, any muscle relaxant in general. So that's definitely an area that we don't have much evidence to guide decision-making. With non-steroidal anti-inflammatory drugs, we looked at both non-selective and selective NSAIDs and found that these provide very small pain relief for acute or chronic back pain. So the effects ranged from about 6 to 7 point reduction on a 0 to 100 pain scale on average. There was a slightly increased risk of non-serious adverse events and that's the general category of non-serious adverse events. But when we looked at gastrointestinal adverse events, there was a much higher risk in that category. So relative risk of 2.5 with a confidence interval ranging from 1.2 to 5.2. Certainly something to be mindful of, particularly in people who have previous history of peptic ulcers, stomach conditions, bleeding risk, etc. Finally, if we look at antidepressant medicines for low back pain, there's actually inconclusive evidence of the effectiveness of these medicines in acute low back pain. Only one trial was identified in recent high-quality systematic review. There's moderate certainty evidence that serotonin, noradrenaline reuptake inhibitors provide very small reduction in back pain, so about 5-point reduction on a 0 to 100 pain scale at 3 to 13 weeks post-administration. And there's very low certainty evidence that duloxetine reduced sciatica 2 weeks or less post-administration. The effects there are actually much higher, so almost 20-point reduction on a 0 to 100 pain scale. Unfortunately, that effect wasn't seen at longer time points, so 3 to 13 weeks after administration, but you can see from the effect estimates here there's certainly some potential with duloxetine for the management of chronic sciatica. But I just wanted to draw your attention to some unanswered questions, which are certainly of interest to me, and maybe we need to think about whether they're worth pursuing in future clinical trials. So first of all, do these medicines provide an opioid sparing effect? Do they reduce the requirements for opioids, for example, or even gabapentinoids? Are benzodiazepines effective for acute or chronic back pain? So at the moment, there's such a paucity of evidence around the use and effectiveness of this particular class of muscle relaxant in the context of acute and chronic back pain. Is paracetamol effective in chronic back pain? Sorry, that's a typo. So we know it's not effective in acute back pain, but is it effective in chronic back pain? And does it have a potentially opioid sparing role? And is the combination of an opioid analgesic with inverted commas, simple analgesics such as paracetamol or an anti-inflammatory effective for the management of acute back pain? So of course, we can consider that other combinations or other opioid analgesic may have a different effect in acute back pain. There's also some interest in whether there is an effect of opioid analgesics compared with placebo in the few hours that administered after the drug is administered. So in the study that I showed you earlier, they looked at the effect over days to weeks, but there's also interest in whether these medicines reduce pain in the shorter period, so following a few hours after administration, and it doesn't appear that that question has been addressed rigorously at the moment, looking at all the evidence that's out there. So I would like to acknowledge a number of organisations. Firstly, the School of Public Health, who I'm affiliated with, Sydney Health Partners for making this presentation possible, and Sydney Musculoskeletal Health. And finally, I just wanted to say, if anyone had questions or are interested in being part of a clinical trial to improve the management of back pain, please reach out. Here's my email address there. At the moment, I am leading a clinical trial that basically is working in partnership with GPs to try and support
I think we lost the last part of her presentation, but it's a great opportunity to get in touch with her and ask her to describe a little bit more of her current work. and hopefully she will be here soon so she can actually discuss that. Now, I would like to invite Professor Paulo Ferreira to present on non-pharmacological management of back pain. So again, Paulo is a professor of musculoskeletal health at Sydney University, School of Health Science, with expertise in exercise and digital health for back pain. So thank you so much, Paulo.
Thank you, Manuela, and I hope the slides are okay on the screen. Thank you, Manuela and Lauren, for organizing these and give me the opportunity to discuss this topic a little bit in detail with the audience today. So my role here is to talk a little bit about possible effects of treatments that are not pharmacological based in the treatment of back pain. And I'll be focusing mostly on exercise, physical activity, and lifestyle modifications. So we know from Christina's talk and from some very historical evidence that some of the common drugs that are prescribed for back pain have some limitations in terms of the treatment effects that they provide. So we probably do need the addition of some benefits from other treatments. The good thing is that we do know that people who remain physically active after an episode of back pain, they're more likely to recover than those who do not remain physically active. And the benefits are promoted in a general sense. If you look at the message that has been described on the Lancet series for low back pain, it's quite clear that mainly exercise are recommended as a non-pharmacological therapy for chronic and acute low back pain. However, when we look at the clinical guidelines for back pain, and we were interested in these as part of one of our PhD students' work, we were interested in how accurate the information on physical activity and exercise are described in guidelines. And so when we look at exercise supervised by a clinician, most clinical guidelines all over the world, they will say something about supervised exercise. However, when we look at self-management, physical activity as a way to prevent and manage back pain, not too many guidelines do include messages on physical activity in general. So this is just a copy and paste from the NICE UK guideline on physical activity and exercise. So they do recommend a supervised group exercise program to people aged 16 years and over to manage chronic back pain. And they are also saying to encourage people with chronic primary pain to remain physically active. And so what you can see from this copy and paste message from one of the most used clinical guidelines for back pain is that the message is very superficial. It doesn't tell clinicians or patients what type of exercise they should do. It doesn't tell people how much physical activity they should engage in. It doesn't tell people what type of physical activity they should do. And so for clinicians, it's really quite difficult to sensibly advise on what type or dosage of exercise or physical activity patients should do. But do the guidelines actually reflect the evidence that we currently have available? Are all exercise the same as the guidelines are promoting? And perhaps most importantly, people tend to believe that physical activity is always beneficial, but is it really the case for back pain? So this is the summary of results of recent network meta-analysis conducted by Jill Hayden and colleagues, and they were able to pull the results of many trials of different exercise for back pain. And if you look at the forest plot describing the effects of those exercises, we will see that the effects of exercise are not always the same. So we do find some types of exercise that are slightly more beneficial than others to improve pain intensity. And as you can see here, mailing some types of specific exercise appear to be superior than other general types of exercise. Now, this is not really new information. We know since 2007, when we did a randomized controlled trial of different types of exercise for back pain, that especially in the short term, some types of exercise can be better than others. So this particular trial, we randomized 240 patients to different types of exercise. And in the short term, we found that motor control exercise, so some people consider that core stability exercise, are superior than general exercise for back pain. Now, fair enough, in the long term, the effects of those exercises, they tend to be quite similar. So in terms of physical activity and self-management physical activity, in other words, not prescribed exercise, the impact of physical activity and different types of physical activities can also have different effects as well. And the guidelines are not telling us that. So this is just an example of a recent study that we finalized. We followed 400 people over 1 year, and we collected weekly measures of healthcare utilization. One of them was pain medication, and we look at types of physical activities that people engaged at baseline. And so what we found was that those engaged in moderate and vigorous physical activity, they were much less likely to take pain medications throughout the year compared to those who were engaged in low volumes of moderate and vigorous physical activity. However, when we looked at physical workload, which is another type of physical activity, we found exactly the opposite. So those involved in high volumes of physical workload were much likely to take pain medications throughout the year to manage their back pain. So different types of physical activities, different effects. So it's not only about exercise and physical activities. When we talk about non-pharmacological treatments, more and more we're finding that there is a very close link between sleep and pain. And there has been trials of sleep interventions for musculoskeletal pain, including low back pain. So this is the result of a recent meta-analysis that we have conducted. So this is pooling low back pain and osteoarthritis. There is a small effect of sleep interventions for musculoskeletal conditions. When we look at back pain only, the effects were actually greater than in osteoarthritis. So there is some evidence that sleep retraining can be beneficial for back pain, especially chronic back pain. So when we lump together different lifestyles, including sleep, physical activity, alcohol, smoking, etc., we do know from recent research that the more lifestyle scores people have, the greater the number of positive lifestyles that people have, including sleeping better, engaging in adequate physical activity, the fewer the days of medication intake that people will need throughout the year as well. So it's not only about doing exercise or perhaps sleeping better, it's about the combination of lifestyle behaviors. And it looks like the more behaviors you've got, the more tools you have not to need other types of treatments for back pain and self-manage yourself. So just in summary, non-pharmacological management can be beneficial in back pain, but we do believe that the clinical benefits are not the same. Different types of exercise will offer different effects. These effects probably vary according to types of exercise and types of physical activity. They also vary according to which outcome we are talking about, whether we are talking about pain or disability or recovery. And it also varies according to different stages of disease progression. Other lifestyles can also be beneficial, especially good sleep. But unfortunately, the guidelines do not reflect this contemporary knowledge in the field. So that's all for me, and I think we'll move back to Manuela. I think I'll just stop sharing this.
Thank you so much, Paulo. All right, I can see some questions popping up in the Q&A box, which is great. So I'll do the remaining part of the, or give the remaining part of the presentation now, and then we'll move on to the panel. So thank you all very much for your attention so far and your patience. All right, so let me share my screen again. Okay, so what I wanted to briefly talk to you about now is the latest evidence on surgical management of back pain. So what we are, or where we are up to. And then in the last couple of slides, I'm just going to very briefly provide a summary of what we've tried to convey today, and also a bit of what we can do to facilitate the implementation or translation of that evidence into practice. Okay, so we do know that surgery for back pain has been, again, the rates have been surging over the years quite drastically, not only in Australia, but also in the US, UK, all over the world. In the UK, back surgery or lumbar spine surgery accounts for around $2 billion every year. In Australia, we have seen between 2003 and 2014 a 16% increase in decompression, which doesn't seem like much, but when you consider that the cost of a decompression can go up to $29,000, that is actually quite substantial. And the increase in fusions has been up to 300%. Now, the question is, does it work? So a while ago, and again, very briefly, I'm going to focus now a little bit on decompression, or laminectomy being the most common type of decompression. So this is when the back part of the spine, so the lamina, is removed, sometimes with, sometimes without ligaments, but that is removed to allow for an increase in the spinal canal diameter. And this is a very common procedure performed for people with spinal canal stenosis, for example, both central stenosis and lateral recess stenosis. So it's actually the most popular spinal procedure in Australia, and the most common reason for older people with back pain to have surgery. Now, we looked a while ago, we looked at cohort studies. So these are not randomized controlled trials. So these are cohort studies, and we plotted them, we meta-analyzed them to try and have a sense of what the trajectory of a patient in terms of pain in the upper box and disability in the bottom box. So what the trajectory of symptoms was since surgery. And what you can see, the trends are very similar. So for both pain and disability, there is a very drastic decrease in pain and disability. This is mostly leg pain, not back pain. There is a drastic decrease, but it's not full recovery. So very few people actually experience full recovery. And the symptoms stagnate over 5 to 10 years. So there is actually no full recovery. Now, when you look at the evidence, and when you look at mostly guidelines, so we know that these procedures are recommended to people with chronic back pain. So again, needless to say that in Australia, guidelines will recommend that people with back pain, whether acute or chronic, they will try conservative care before they are referred to a surgeon. So now we are talking about chronic patients with persistent or chronic pain. Now, when you look at the guidelines, most guidelines will not recommend invasive or surgical procedures for chronic back pain because of the lack of evidence supporting those. So let's have a quick look at the evidence. And I'm just going to go through some of these, not all of them, I'm just going to go through some of these. Now, let's have a look at, for example, injection therapy for subacute and chronic low back pain. So a Cochrane systematic review. Sorry, there is a little bit of a glitch in my PowerPoint, and I apologize. So a systematic review, a Cochrane systematic review done in 2013, included 6 trials, not too many trials. And what they actually noticed was, so these are injections for facet joint osteoarthritis. So what they noticed was moderate evidence that facet joint injections of corticosteroids are no better than placebo. At the short term, conflicting due to lack of high quality trials at the intermediate term, and limited of no effect on return to work. So very thin evidence there, unfortunately. Now, when we look at total disc replacement for chronic low back pain in the presence of disc degeneration, there was also another systematic review, Cochrane systematic review. And as you can see, there is, again, not very good evidence that that procedure is better than conservative care for patients with disc degeneration. I'll just go to the next one. Now, when we look at decompression, going back to that first slide that we talked about in terms of laminectomy, when you look at decompression for lumbar spinal stenosis, both central and lateral recess stenosis, there has been a couple of systematic reviews. The latest systematic review, Cochrane systematic review, identified 5 studies comparing decompression to conservative care. The final conclusion is that there is no convincing evidence, or there is conflicting evidence, that laminectomy is better than conservative care. Conservative care varied a bit across those 5 studies, but it ranged from advice and pharmacological interventions to physiotherapy. After that systematic review was published, Toledo published an RCT looking at laminectomy versus best evidence physiotherapy care, showing again no difference between groups. So there isn't any convincing evidence that laminectomies are better than conservative care. Interestingly, some years ago, when we looked at the evidence to try and identify whether laminectomy was better than no treatment or placebo, we couldn't find any studies. So we actually ended up doing a systematic review looking at the comparative effect of many different types of procedures, because there are no trials looking at laminectomy versus no treatment or placebo. The limitation of the 5 trials included in this systematic review, plus the Toledo trial, is that when you are comparing surgery to non-surgical treatment, it's very, very common to see crossovers between non-surgical to surgery due to lack of equipoise. So this is basically because most patients will have tried some conservative care before having surgery. So when you randomize them to either having surgery or conservative care again, it's actually hard to establish that clinical equipoise among patients. So all of these trials included in the Cochrane review and the plus Toledo trial had very high rates, up to 40% of crossovers. And so randomization was actually breached. And the final result was a biased result, unfortunately. So very recently, we have designed and got funded and have started conducting a placebo-controlled trial of laminectomy for spinal stenosis. So SUCCESS, which some of you may have heard about. SUCCESS is a trial that we are currently conducting across 9 sites in Sydney and 2 in Melbourne. In the trial, we are randomizing patients to having either full laminectomy or placebo laminectomy. These are patients with central canal stenosis and who come with neurogenic claudication as being the main complaint. So these are patients with typical central canal stenosis. They could have lateral recessed stenosis as well, but the main component driving their symptoms is actually the central stenosis. Now, they are randomized in theater to either having the full decompression or having the surgery, but with no removal of the lamina. So they are randomized at the point of the removal of the lamina. We then follow these patients up at 3 months, 6 months, 9 months, 12 months, and 24 months, and we are collecting a number of different outcome measures. The primary outcome is function. We have 2 co-primary, function and neurogenic claudication or walking ability. We've had 40 patients randomized. COVID has, of course, really affected our recruitment. We have 40 patients randomized, and we're looking at randomizing quite a few more. So if you're interested in hearing a little bit more about SUCCESS, please let us know. Now, a similar trial that we are conducting with surgeons in Finland is FinDisc. So this is actually microdiscectomy compared to placebo for subacute sciatica. Exactly the same as SUCCESS. So patients are randomized in theater, and there will either be removal of the disc or part of the disc if they are in the discectomy group, or no removal of the disc whatsoever if they are in the placebo group, and they're followed up for 3, 6, and 12 months. So this trial hasn't started yet, but it's been funded in Finland, and it's ongoing. So I'll probably just very briefly go through the summary. Again, the idea here is to provide a little bit of the most up-to-date evidence on management of back pain. And we did try to get a bit of everything. The message sounds negative at times, but it isn't negative. We do know that some treatments work and some treatments do not work for back pain, as for any condition. In summary, what we have been gathering from research, past research, is that back pain should be managed in primary care. So this is really where back pain should be managed. Specialist care, it's for a very, very small and specific subgroup of patients. And research hasn't been able to accurately identify the characteristics of that subgroup yet. Education and advice should be provided to patients. So this is, there's quite a bit of evidence actually reinforcing how important it is, education and advice. And we heard from Melissa how important that is from a patient's perspective as well. Patients should remain active and stay at work. There is quite a bit of evidence, again, supporting that moving and staying at work are extremely important prognostic factors for back pain. First choice of therapy should be non-pharmacological. Most guidelines internationally have actually adopted that approach as well, given, as Christina was saying, the lack of evidence supporting pharmacological approaches and the good evidence supporting the non-pharmacological approaches, as Paulo has mentioned. In terms of physical modalities, electrophysical modalities, such as shortwave, diathermy, TENS, and other modalities such as traction, for example, there is very, very thin evidence that they work, or evidence that they do not work and associated with adverse events. So most guidelines advise against them. Exercise is recommended for chronic back pain. Moving is recommended for everyone. And again, a biopsychosocial framework should be the guide for management of back pain. Now, especially given Melissa's presence here, as a research community, we do acknowledge that talking about evidence, whether to clinicians, patients, other researchers, is one thing, but then translating that evidence into practice is actually something else, and it is a challenge. And I don't think that researchers necessarily always do a very good job at communicating the results of their studies, or their findings in general. So some of the initiatives that we've tried to do as a group is actually bring that evidence closer, or that information to patients a little bit more efficiently. So some of the studies that we are doing at the moment is Text from My Back. So Text from My Back is a low-cost access to best evidence self-care or self-management. It's a self-management approach based on healthy lifestyle tips or recommendations, which are delivered through text message. So patients are with acute back pain or non-persistent back pain up to 3 months. They are randomized to receiving either a series of text messages over a period of 3 months. So they receive approximately 3 to 4 text messages a week for a period of 3 months. And these messages are, just to give you an idea, on different topics such as exercise, education, mood, use of care. And the idea really here is to improve knowledge and empower patients into managing their own symptoms. So this Text from My Back trial is nearly finished. We have 20 more participants to recruit out of 300, and we'll be able to provide results soon. And the other approach that we are using is HELP. So HELP, and we are actually working with this PHN on delivering health. So HELP will be a stepwise randomized trial looking at the efficacy of a video intervention on improving general knowledge about management of back pain. So with Tonic Health Media, we have produced a video talking about some of these messages that we are discussing now. And it's going to be displayed at some waiting rooms of some GP clinics. And this is really, the idea is really to get patients to understand a little bit more about management of back pain, or evidence-based management of back pain, and to facilitate that conversation with their GPs. I'll stop here. I just wanted to, again, acknowledge and thank the collaborators that we've worked with. And again, Sydney University, the NHMRC for funding us and our research. And I'll stop sharing. And we are probably ready for some questions. And we've got quite a few questions in the Q&A, which is great. So I'll ask, Melissa is here, Paulo is here. I am not sure if Christina is here, but I'll start with some of these questions. But if it's okay with the audience, I would like to start with you, Melissa, and just get your input on some of the points that we were discussing. And again, from your perspective, I was wondering, when you're talking, what kinds of messages have you actually heard from different people, not only clinicians, but researchers, clinicians, neighbors, in terms of back pain and what you can and what you cannot do?
It really seems to be a lot of contradictory kind of things, where you get some people, whether they're, like you say, whether they're just people that or some professionals saying, oh, make sure you rest your back and, take it easy and that kind of thing. And then other people like, no, toughen up, walk it off, that kind of, but almost too far, I think, like, go run a marathon, that'll fix it kind of ideas. So, yeah, I think a lot of really opposing kind of opinions, and nothing that's probably a bit more moderate.
Yeah, which is very interesting. And again, it goes back to what I was saying about how we disseminate research, and I think we need to do a better job at discussing and talking about what actually the findings mean to the patient and to the clinician.
Yeah, and I suppose especially for the average person, they see these sound bites in the media that aren't necessarily explaining everything that's actually in study findings or that kind of thing, and that's where people translate exercise is good for back pain to go run a marathon, that'll fix your back, the kind of thinking.
Yeah. And what would you, this is the last question before we go to the questions here, but what would you like to hear, when you're going to your clinician? Again, it could be primary care clinician or surgeon, or what would you like to hear? What kind of information do you want when you see your clinician for back pain?
I think that the two main things for me would be, I guess, having the confidence in knowing that the information that they are giving me is correct for my condition, is the most up-to-date information, but also that the kinds of things that they recommend are something that is, I guess, doable for the average person. So like I was sort of, mentioning before, taking into consideration that, people work, they've got families, that we're busy and we can't always, do these exercises that seems like 400 times a day. And, I've sometimes been given things and I'm like, yeah, but I work and I have kids, I've got my kids to look after, and I've got to get to and from work. Where am I going to fit this in? So I think something
realistic.
Something that's actually, if it's realistic, I think people are more likely to do.
Yeah. All right. That's really good. All right. Thank you so much, Melissa. We'll go to the chat and then we'll probably come back to you again. So one of the questions, this is probably for you, Paulo. What exercises can GPs tell patients to do? This is a great question. To do who have severe acute back pain and spasm. For example, lie on the side and get someone to rock the pelvis and shoulders move in opposite directions that physios tell them to do, etc. Practical advice appreciated, which is exactly what Melissa was talking about. Yeah,
it is a great question indeed. So, I mean, when patients have very high level acute pain, it is difficult to convince them to get up and exercise. That's just the reality, I guess what we want to do is minimize that bed rest time as much as we can. So at the end of the day, any exercise is actually better than no exercise at all and bed rest. So if you can convince your patient, I'm assuming that in this particular case scenario, for example, there is a lot of back pain spasms. Maybe the patient is not even able to come to the clinic, and the patient is calling the doctor, etc. So if you are able to convince the patient that any kind of mobility, simple mobility exercise in bed, if the patient can do that, that's better than nothing. I also think that in most cases, patients cannot move, not so much because of the pain, but because of the anxiety that pain brings as well, and the fear of moving. And so if you can explain to patients that, most cases of back pain, there is really not serious happening. There is pain, and the pain can be severe, but it's very unlikely that something more nasty is happening, whether it's a fracture or a tumor or anything. And so, number one, any kind of movement is better than nothing, whether it's just mobility exercise in bed, whether it's just trying to stimulate the patient to get up and just go for a very quick walk and come back. And I guess the way to achieve that, it's probably through trying to reduce that anxiety. Now, we have to remember that one of the most powerful treatments that clinicians do have for back pain is actually advice, but we've got to know which advice to give. And the best advice you can give to your patient is that there is probably nothing serious happening with the back pain, and maybe that might help your patient to get out of bed.
So, Paulo, there is a question also related to this one, and maybe I'll go to you with that question, but I would love to hear from Melissa as well, what she finds useful in terms of, tips on how to move and types of exercise. But I'll go to Paulo first, just because it's similar to the previous question. So the question is, can we get more specific info on type of exercises which are useful?
Yeah, okay, all right. So if we're talking about the long-term outcomes, most exercise will produce very similar effects. But that's in the long term. And so if you can discuss with your patient a long-term plan, you've got to consider what the patient likes doing, whether the patient has private health insurance and can afford seeing a physio, whether the patient has access to a gym or to a park close by. But that's considering the long-term effect. So, if the patient likes doing, walking, or if the patient likes swimming, or if the patient likes lifting weights in the gym, in the long term, it's very likely that no matter which type of exercise the patient does, the benefits will be pretty much the same across different types of exercise. Now, the question is in the short term. And so in the short term, there appears to be some types of exercise that are slightly better than others. And these are usually more specific exercise that require supervision. And most of the time it is supervision by an allied health person or a physio. So we're talking about Pilates exercise coming high on the list, Mackenzie exercise, which are spinal specific exercise that are prescribed for mobility, and what we also call motor control exercise, which are also types of exercise that help patients to contract the right muscles. But these exercises probably do need the supervision of someone who knows how to prescribe them. But they are the most, probably the most superior in the short term. Now, again, in the long term, the good news is that any exercise can be helpful.
Thanks, Paulo. And so, Melissa, in terms of that practical advice to move yourself, from a patient perspective, what is useful and what is not useful? Because you just said that if we tell you, for example, of course, run a marathon, that's not going to be very useful.
Yeah.
But what's useful and what's not useful from a patient's perspective?
I think especially for me, so I've got a desk-based job. I work full time. For me, something that a physio recommended to me was just some really short exercises that, gosh, it feels like it takes a minute kind of thing. So, you know, people don't even laugh at me at work anymore. If I stick, you know, my lunch in the microwave, or I'm waiting for my coffee to come out the coffee machine, or boil the kettle or something like that, they're just like really simple stretching exercises that, you know, you don't need to sit down or lie down to do. You do them standing up, and yet they take 30 seconds. And I kind of have it paired in my head now, do these things when I've got something in the microwave. And I guess also that that's sort of like, more incidental exercise. So I've got some people at work that I can convince to have a walking meeting with me rather than sitting down, or, you know, trying to find some activities that are like, I'm not really one for walking around and just looking. So like as a family, we've tried going to markets more, so where you're really walking around outside, walking, you know, quite a fair bit, and that's been really quite good as well.
Perfect. And you know, going back to walking and that first question about the very acute patient, and I've had very acute episodes of back pain as well, and so when you tell a person with a very acute episode of back pain that you need to walk, you need to exercise, that's really not going to go down well. But doing that 1-2 minute walk or mobility, you know, just to move your back a little bit in that first acute phase, it's actually to the level that you can tolerate. It's actually a practical and welcome advice, I think.
Yeah. I think even I've had you know, that was something that a physio recommended to me was, you know, go for a walk. They're like, even if it's literally walking up and down your hallway,
exactly,
that's better than nothing. And so, you know, that was what they said to me. You know, if you can't walk much, you know, just start going, you know, from the lounge or wherever you're sitting to the other end of the house and back again, and then do that a few times, see if you can double it. You know, 5 minutes walking around the house is better than nothing. So
park your car. I usually do this when I go to work, park my car far away so I can walk a little bit more. If you need to go to the printer that is further away from you, so you can actually squeeze
do that
in.
at work too.
Yeah. Very nice. Now I need to do a better job at going through those questions. Now, what sleep interventions helped? Is it just about the usual sleep hygiene? And I'm guessing this is for you as well, Paulo. Would melatonin help, or adequate analgesia to reduce pain and disrupted sleep?
Yeah. So most clinical trials of sleep interventions for back pain, they use cognitive behavioral therapy for insomnia. And they appear to be effective. There are some apps in the market now that can deliver CBT sleep for patients with insomnia and chronic pain. So the usual sleep hygiene treatment probably is not going to be sufficient. So you probably do need a little bit more than that. Now, I'm not a sleep researcher myself, but with our studies in sleep, when I talk to my sleep colleagues, they also say that the aspect of sleep that is most effective, sleep treatment that is most effective in general, is actually sleep retraining, and that is basically teaching patients to use the bedroom as a place to sleep. Now, the Woolcock Institute has some very interesting sleep programs for people who suffer from chronic insomnia and pain as well. So that's an interesting place to go. So I think that you probably do need a little bit more than just sleep hygiene. Now, melatonin for back pain, There is no study of melatonin for back pain. We've been talking to some colleagues at the WUCOP to set up a study on this because we think it's quite a relevant question, actually.
Thank you, Paulo. What practical things can GPs do in examining the patient and taking history that indicate, the cause is disc, not other mechanical? So this is a tricky question. It's a good question. It's a tricky question. So there are actually questions that we collect in the history, right, that will suggest pain is coming from the disc. For example, pain that is exacerbated when the patient is coughing or sneezing, pain that it gets better when you're in extension and worse when you're flexing. Depending on whether or not there is any, because of the disc, there is any nerve root compression. The pain could be the sciatica type of pain, as you know, or the more central pain. The question is, will that change management? And the answer is usually no. So whether pain is coming from the disc or the muscle or even the facet joint, there isn't any indication. Apart from radiofrequency ablation, there are a couple of trials suggesting that it does work for facet joint pain, and less so for discogenic pain. But in terms, for example, of exercise or any other non-pharmacological intervention, there isn't an indication that the management would change, because if it's the disc, there is a higher chance of the treatment being more effective than if it is the facet joint. Now, in terms of surgery, there is obviously, there are differences. Now, we do know that discectomy, there is some evidence suggesting that discectomy can provide some relief for sciatica. But again, these studies have some methodological limitations. So this is why we're doing the placebo trial of discectomy. So again, if it's not surgical, and when it is surgical, so of course imaging will show that. But if it's not surgical, if it's non-pharmacological, there is less of a need to identify the disc as opposed to the facet joint or the muscle. Now, GPs are very practical. Can we please have some useful tips in management rather than just saying that this doesn't work much? I agree with you. This is what we are trying to do, because I completely agree with you. I think some of the tips are, and again, there are so many confounders in the things. You quote patients who may have worse back pain, indicate what we are supposed to do acutely. Okay. So if there are a couple of take-home messages, they would be to reassure patients that there isn't anything serious happening to them. So, you go through the red flags. There is no concern for any serious pathology, and no concern for any specific cause of back pain. So reassuring the patient of that, that's number one. Number two, advice in terms of being active. And like Melissa was saying, being active doesn't mean, can you please sign up for City to Surf next month because you have back pain, you need to run City to Surf. But being active is no bed rest. So bed rest is not necessarily, bed rest is the only intervention that is worse than doing nothing. So there was a trial looking at bed rest versus control, and it was worse than control, because control, in the control group, they actually moved. So we know that patients need to move up to their tolerance, but they need to move and stay at work. This is the other tip that is really important. So stay at work or go back to work as soon as possible. In terms of imaging, we do know that imaging or the findings from imaging do not correlate with severity of symptoms, and in many times they actually change management in a way that doesn't necessarily need to be changed. So reassuring patients will actually decrease that need from imaging as well. So these would be the quick and hopefully practical messages. Paulo, would you like to add anything?
Yeah, so it looks like it's the same person that is asking a couple of similar questions here. But so it goes back to this case of someone not being able to move, and we know that NSAIDs, for example, they offer some effects for acute low back pain. They're not fantastic, but they can help, as opposed to paracetamol, for example. So right there, you've got something that you can discuss with your patient. And this is clustered with some other questions on what physios can do for in this case, and so physios usually use manual therapy techniques that they have very good indication for acute low back pain, and they've got evidence that they help in acute and even chronic low back pain as well. And so this is for patients that can do a lot of exercise, can move around. And I guess also related to this question, there is another one, asking, be specific, what type of exercise can be helpful. So, if I can be brief, if we're talking about acute back pain, Mackenzie exercise are effective for acute low back pain, and motor control exercise are effective for acute back pain as well. But it's very likely that the patient will need to see a physio for that. Otherwise, you are left with the option of having a good discussion with the patient, explaining to the patient what could be wrong and what might not be wrong, trying to convince the patient to do simple mobility exercise in bed, rotating the spine, trying to bring the legs to the chest, simple mobility exercise that can alleviate the pain. And hopefully the patient can progress to something more specific after that.
Thank you, Paulo. I think that actually answers the next question, which is what's the role of physios, manipulative physios with acute, chronic, and osteopaths. So I think you've answered that question. So thank you. Now, we've been told that if the pain is local, i.e. at the back, surgery won't work. But if it's referred, for example, bad sciatica, then back surgery works. Is this true? Not necessarily. So as we mentioned before, the evidence is quite controversial for both non-specific back pain and for sciatica or stenosis. Having said that, there have been a couple of trials looking at fusion for non-specific low back pain. They're older trials, they're being replicated now, and we are actually looking at whether fusion works for non-specific back pain. In the UK, for example, fusion has been removed, so they will not, the government will not, NHS will not fund fusion for non-specific back pain, and so non-sciatica, because of those older studies. But they are being now replicated both in the UK and here in Australia. So not necessarily true that we need a lot more evidence to support either one. Now, physiotherapists claim that they can help spinal stenosis. Is this true? So again, there is a trial that was conducted at Oxford University not long ago. They looked at exercises for spinal stenosis versus usual care. So there was some evidence that exercises for spinal stenosis, so physiotherapy for spinal stenosis, was better than usual care. So there seems to be evidence supporting physiotherapy for spinal stenosis. So yes, my answer to that question, yes, physios can help spinal stenosis. Now, acute severe back pain with sciatica symptoms. If the patient goes to hospital ED, most of them are given pain medications and sent home and told to see the GP for strong pain medications like Edone and Tramadol. This is difficult for us to manage. I absolutely understand that. Yeah. And this is probably something that I would like to again ask Melissa, that expectation that patients come to the GP with, so I need my medication and I need my X-ray, because I know that this sometimes puts GPs in a difficult situation, especially if someone else, another clinician, has told them this is what you need. Go to your GP and discuss this with them. So it would be great to hear from you very briefly. Sorry, because we're running out of time, Melissa. What your opinion on this is?
Look, I think it might depend a little bit on, say, the patient's background or something like that. I think even knowing myself what my opinions are on whether, I should go straight to medication for something or to try something else that's, different than what it was, say, 15, 20 years ago. So I think hopefully the more that the general public becomes educated in that kind of thing, and I think gradually people are now, so it might be unfortunately a little bit of hard work for the GP to try to explain that. I don't know if they can stop the ED from doing that, but
there are a few studies going on now at the ED setting to try and change that.
And you can understand it's hard for them as well, trying to deal with so many different cases. So
absolutely,
it's understandable.
So one of the approaches is to actually have a physio in the ED for non-specific back pain cases, and then the physio will actually guide the patient. Now let me try and go very quickly through these. So we've answered that sometimes we see people who have severe back pain, we can educate. Okay, so sometimes we see people who have severe acute back pain, we can educate them and tell them medication doesn't work and they can't even move without pain and lying down. What do we do? Do we refer them to a physiotherapist, allied health, or should it be a manipulative physiotherapist? Okay, these are great questions. So I'll very, and Paulo, if you have anything to add later, but very quickly, the main problem with the prescription of medication is that for most patients, there is a prescription of medication and that's it, with that expectation that medication will take away their pain, which is not true. And we all know that back pain is a multifactorial disease and very much related to lifestyle. So if you, having that chat with a patient, believe that, for example, non-inflammatory steroids will actually help them, and you want to prescribe that medication, because this is really a patient clinician decision. If you want to prescribe that medication, make sure you also prescribe some exercise and advise to stay active. So if they need to take a medication to make sure that they actually can move, make sure that they do move. So that would be one suggestion. Now, physio, absolutely. If they need to, if they need guidance, if they need to know how they need to move, if they need guidance on how they need to exercise, absolutely, they need to see a physio. So that would be definitely the suggestion. Now, the next one, according to this in newspapers, most back surgery is unnecessary. So should we ban surgeons from doing it? No, I don't think so. We should, because there is, and thank you for this question. There is definitely a subgroup of patients who do benefit from surgery, and there are types of procedures who do seem to work. We need evidence to both identify that subgroup, and we need evidence to understand how much benefit they offer, especially given the costs and the complications associated with surgery. So we're not there yet. I don't think we should ban surgery. Now, I'm very much aware that it's 8:32, and I think we need to finish now. I'm really sorry I haven't gone through all of the questions. Happy for them to be sent to us, Lauren, and we can go through them. I hope this has been useful. And I really want to thank again Melissa and Paulo for joining.